So today we're going to talk about G and J tubes, and this talk will be in addition to the slide deck that you have. Okay, I'll try and keep as close to the slide deck as I can, but there'll obviously be a little bit of meandering as you know. The first thing, and it's not in your slide deck, is today we're going to just have a brief review of NG tubes and feeding tubes. Okay, so we've got NGs. And these NGs, nasogastric tubes, remember they serve two purposes. One is to decompress the stomach. And why are we decompressing the stomach? We're decompressing the stomach for two reasons. The first one is to stop any air that we swallow accumulating in our stomach. And remember, we usually put in an NG because we want to stop people vomiting. And when we want to vomit, we become very aerophagic, i.e. we swallow lots of air. So that's why we want to put in the tube to get rid of the air. The second reason that we want to put in a nasogastric tube is to decompress the more proximal small bowel. Okay? And that's usually to get rid of any backed up enteric contents. So there are two types of NG that we have. One that you see more commonly is the type of NG that's shown here. Okay, it has just the tube and it has a blue end or a green end. And these come in different sizes ranging from a 6 French all the way up to a 16 French. The thing about this tube is that it is not a vented tube. Okay, so that means when you use this tube and it has just one end, you have to put it on to intermittent suction. Okay? The intermittent suction is controlled by the dial that the nurse has at the bedside, and she puts it on a level which is low intermittent suction. Okay. The other type of tube that you'll see around is this type of tube, and the colloquial name for this is called a rapogle. And see that this tube has two ends. It has a venting end, this one here. Okay? This is not the end that you put to the patient. This is the end that you put to the patient. This is a venting end. Okay? What this does, it allows, as the tube sucks things out, it allows air to be sucked in, and it stops the mucosa at the end of the NG getting trapped in the NG. So this tube can go to continuous suction. Okay? So this one goes to continuous. Okay. We prefer this type of tube. It's much more efficient. And there are specific times that we prefer this tube. This is the only tube that works when you have a TEF. When you have a tracheoesophageal fistula, this is the only tube that works to decompress the proximal pouch. Okay, so remember that. They're quite difficult to come by, and the problem with them sometimes is that fluid leaks out of this tube, and that's this end, and that's why people don't like them as much. But they are far the most superior type of nasogastric tube to use. Okay. One thing that I also want to touch base on right now is using a Mickey button to vent the stomach. Okay, so we'll talk a bit more about the Mickey button, but what you need to remember about the Mickey button is that this is the Mickey here, the top of the Mickey, with the little access port here. You have the tube that goes to the balloon, and the end of the Mickey button is here. This end of the Mickey button sits in the stomach, right? But it doesn't sit in the bottom of the stomach, whereas an NG you can push to the bottom of the stomach. So the Mickey button is good for decompressing air, but it's not good for decompressing liquid. So if you have a patient who comes in who you really want to decompress liquid from the stomach or small bowel contents from the stomach, just using a Mickey button is not good. You need an NG. Okay, that's just a quick reminder of that fact. All right? Okay, so there are 3 or maybe 4 different types of gastrostomy tubes that you need to consider. There's the surgical gastrostomy tube. There's what we call the PEG gastrostomy tube, which is the percutaneous endoscopic gastrostomy tube. There's the interventional gastrostomy tube, And then there's the one that we most commonly use at LHSC, which is the laparoscopic gastrostomy tube. The indications for G and J tubes, you really, the bottom line is it's going to be failure to thrive. Okay, so inadequate intake. What is the reason for the inadequate intake? We need to know, because we need to be able to figure out if there are other ways to do it. But the bottom line is it can be for many, many things. So for neurological impairment, for a degenerative disorder, for congenital anatomic abnormalities, and for metabolic disorders. You know there's a wealth of things that it can be. Okay, next slide. And the big question for us is, as the surgeon, and for you as the pediatric resident or the medical student, is, well, what type of tube do we choose? The first choice for our institution, and in fact probably for most institutions, it's going to be what we call the laparoscopic G tube. So this G tube, as I mentioned, is certainly the most common. When can you not put this G tube in? Well, you can't put this G tube in if your patient has had many, many, many abdominal surgeries. We always try, but we might not be able to do it. The other time that you won't be able to do it is if we don't think that the patient will tolerate a pneumoperitoneum, so gas in the intra-abdominal cavity, increasing the intrathoracic pressure. It's also very difficult to do if we have a tiny baby. We are gradually creeping down, like at first it was 5 kilos, but I think probably the upper limit now, or the lower limit, sorry, is going to be around 3.5 kilograms. Okay, and that's when we say we really just cannot do it anything less than that, because the babies are just too small. So as I said, if it's less than 3.5 kilos, probably what you're going to need to do is choose a surgical J tube, okay? A surgical G or J tube, and we'll talk about that in a minute. One of the key things to remember is that if your patient needs a GJ, right, up front, so they're not tolerating feeds through the stomach, and you think that they should have a GJ, you've had an NJ in, and now you think you need a GJ, we cannot do that laparoscopically. The best people to do that is through interventional radiology, and this is the reason why. When you have a GJ, you put the tube into the stomach through the anterior abdominal wall, and then you feed it from the stomach, so esophagus, stomach, tubing going in here, and then you feed an extension tubing round into the duodenum, beyond the duodenum, and you leave it in the jejunum. Okay? We cannot do that laparoscopically. Because we don't, often in the babies that we're doing it in, we don't have the right guide wires in the operating room to be able to feed it around. Also, it requires a lot of fluoroscopy time. We don't have access to intermittent fluoroscopy in the operating room. And if we do have access to it, it uses a very high dose of radiation compared to that in interventional radiology. So, your patient needs a GJ up front, okay, they need to go to interventional radiology. Interventional radiology, I can tell you right now, will not be keen on putting tubes into small babies, okay? So you have to kind of go speak to them and find out what they feel about it. Remember that if we put in a laparoscopic G tube, it can be converted to a GJ in about 6 weeks. So 6 is your magic number, okay? Remember, when you're talking to parents about a G tube, when you put in a G tube of any description, you are often putting it in for gastroesophageal reflux, okay? Gastroesophageal reflux, or your GERD, it gets better, so it decreases, in 30%. It stays the same in 30%, but unfortunately sometimes it increases. in 30%. What do you say? You say 60% of the time it's not going to change anything, so it's probably a good thing to do. All right? This is the laparoscopic, endoscopic G-tube. And if you look at the slide deck, you'll see how it's put in. But I'll just review it because sometimes just explaining it verbally makes it easy to understand, right? So you have the stomach here. And what we do is we put in the telescope, so the abdominal cavity here, this is the belly button, so we put in the laparoscope, right, through the belly button. We look at the stomach, and then we pass an endoscope down the stomach. We inflate the stomach so that it's really pushed up against the abdominal wall here, okay? Then, using a needles, and what we call these little T-fasteners that look like this, we puncture the anterior abdominal wall, 1 and 2, okay? And we slip these T-fasteners into the stomach so we can see them with the endoscope. So then we end up with pieces of string coming out, and this little T-fastener sits on the inside of the stomach like this, okay? So these T-fasteners pull the stomach up against the anterior abdominal wall. Remember, when you see a patient who's had a G-tube, what you see on their anterior abdominal wall will be a Mickey button here, and then on either side you'll see these clear plastic buttons, okay? These are the tops of these T-fasteners here, all right? Then, under direct visualization, using the endoscope, we place the Mickey button through the anterior abdominal wall and into the stomach. Okay. So when we first look with the scope, what we see here is we see the anterior abdominal wall, I'll put here. So we see the anterior abdominal wall here. The stomach is pulled up against the anterior abdominal wall on the inside. And we see the Mickey button sitting on the outside here. And remember, this is what your Mickey button looks like this. You see the Mickey button here, like that. And then what we do is we inflate the balloon right here, okay? And we inflate the balloon just like this. Syringe doesn't work. So we put the balloon into this port here, and then we inflate the balloon. And the balloon here will blow up, and it holds it in place. All right? So the Mickey button is then in place. The thing about this Mickey button is that it mustn't be dislodged for about 6 weeks, because if it does get dislodged, then we lose the tract. Once the Mickey button is in place, there are a number of things that you have to do. The first one is you have to consult a dietitian. Okay? And she is going to provide you with a feeding schedule that's appropriate for your patient. You're also going to reconsult or let the gastrostomy team, so Danielle, know that the patient is in and that the patient might need some teaching before going home. In the immediate postoperative period, so in the first 24 hours, we don't do anything to that G-tube. We leave it alone, we don't use it. You can use it for meds, but that's the only thing you should put through it. And the patient should be NPO. The day after surgery, provided it's not complicated, then we usually start some Pediatric through the G-tube. And then we start to gradually work up their feeds, okay? If in the immediate period this tube falls out, general surgery should be consulted immediately, okay? Nobody should push that tube back in, right? Recently we've had a number of events where nursing has pushed the tube back in. That is completely the wrong thing to do, okay? Consult general surgery, get them up straight away, get them to put the tube back in, and then we do a tube check, and that's where they go down to interventional or go down to radiology. Dr. McKillop or whoever's on squirts some contrast through the tube and make sure it's in the stomach. Okay, now we're going to talk about the surgical G-tube. And you're going to say, well, Dr. Jones, the last one is a surgical G-tube. You put in a laparoscope, you take them to the operating room, you put in an endoscope, you do it in the OR. Well, you're right. But this one, the surgical G-tube, is more of a G-tube that is associated with a laparotomy incision. So if you remember, when we put in the laparoscopic endoscopic G-tube, it's just a small hole around the belly button, right? One laparoscopic port. When we put in a surgical G-tube, as we call it, it's usually an upper midline laparotomy incision like this. Okay? As I mentioned, when we use it when the patients had many abdominal surgeries. And the other thing that you have to remember is we use a surgical G-tube when we have an esophageal atresia. Okay? Oh, let's go. Oh, yeah. When we have an esophageal atresia. So a pure esophageal atresia, right, where we have a long gap and we have the stomach, because you have no connection to the stomach, so you can't get down into the stomach with the endoscope. And then we have to place a surgical G-tube. Nice little pearl is that in esophageal atresia, because the stomach has never been used, the stomach is very small. So it's technically very difficult to place that surgical G-tube. Okay, so what device do we put into the surgical G-tube? It's technically, remember it's all about us making it easy for ourselves, it's technically difficult to put in a low profile device. The low profile device is the Mickey button. It's technically easier for us to put in something that is more of a tube. And one of the most classic tubes that we use is the Foley catheter. But it's the same principle, right? We insert the tube into the stomach, we inflate the balloon, and then the balloon pulls back against the stomach and the anterior abdominal wall. And there's a great picture of that in your slide deck. Okay? Often we'll also use something called a Corpac tube, and the Corpac tube looks identical to the Foley catheter, with the exception that there is a flange that sits right at the level of the skin, right here. So this will be the skin, and then this is the stomach, and there's just a plastic flange that sits right here. The smaller the baby, obviously the smaller size tube we put in, and the same rules apply, is that you, if that tube falls out, especially prior to 6 weeks, you need to call general surgery and you need to get them in quickly to replace the tube. So we've done the laparoscopic endoscopic G-tube, we've done the surgical G-tube, and now the IR-placed G-tube. Any patients coming from sick kids will have an interventionally placed G-tube. There's a very nice picture of that type of tube on the slide deck. Usually what this type of tube is, it's a Cook catheter. Okay? A Cook catheter is usually placed, and the size that's used is either an 8 or a 10 French. And you're going to say, well, you haven't told us what the French of the Mickey is, and you're absolutely right, I haven't. The French of the Mickey that we usually place in the operating room is a 14 French. This tube is much, much bigger. Okay? So the advantage of placing the laparoscopic endoscopic low-profile device is twofold. One is, firstly, it's a low-profile device. There's no tube hanging out. And secondly, we usually place a much bigger tube. The bigger tube allows for higher flow rates of feeding, and it really accommodates medications much better. They don't the tubes don't get plugged up as much as with the small Cook catheters. So that's the advantage of placing the low-profile Mickey device in the operating room. They both have to have a general anesthetic anyway. The disadvantage of placing the low-profile devices, they do have to have a laparoscopic incision as well. The Cook catheter, when it's placed under general anesthetic. They insufflate the stomach with air, and then basically they blind puncture the stomach. It's a very good gastrostomy tube. It works very well. And the only problem is, as I said, you don't get the low profile device, you get a tube that's hanging out and you get a small caliber tube. With this small caliber tube, you leave it in for 6 weeks, and after 6 weeks you can easily remove it, and you can upsize the tube. Sometimes that can take time, and sometimes we can upsize it directly, depending on the circumstances of the patient. But usually what we do is we remove the cook, and then if it's an 8 cook, for an example, we'll then place a 10 French Foley, send them away for a few days. We bring them back, then we place a 12 French Foley, and then we bring them back again and we place a 14 French Mickey. Okay? And Danielle does that, or myself and Dr. Buda tend to do that. And that's one way of handling the cooks. So we really don't use very many cook catheters here, but as I said, if you get any patient from sick kids, that's probably what they'll have in place. The fourth type of device that we're going to talk about is the PEG tube. So the percutaneous, P, endoscopic G tube, or gastrostomy tube. You will see this device from patients that maybe come from Hamilton and from other centres around Ontario. It's not as commonly used as it was 5 to 10 years ago, because we think there are high complication rates from it. It's very commonly used in the adult world. And as you can see, it's not a balloon at the end, all right? It's a flange. So you have the tube, and then you have a flange. And this is the flange that sits on the inside of the stomach. And the thing about the flange is it's compressible. So when you put the tube in, it's compressible to this shape. When you pull the tube out, it's compressible to this shape. And then it kind of opens up like an umbrella on the inside. And that holds it in place. It's placed exactly the same way as we do the laparoscopic endoscopic tubes, but without the laparoscopy. Okay? So what you do is you just put the endoscope down into the stomach, you insufflate the stomach, and then using what we call a push-pull technique, which is described in your slide deck, and I won't spend time on it today, you insert the PEG. It's a tail device, right? So it's like the Foley catheter, it has a tail. It's not a low-profile device. So that's why we don't tend to use it here, because it gives you a tail. The advantage of the device over the laparoscopic endoscopic PEG is the laparoscopy bit, right? You don't need the laparoscopy. One of the complications of putting the PEG in, which is why it's not as commonly used, is that if you go back to the old anatomy days, remember you have your stomach, you have your esophagus, you have your stomach. And if you remember all the pictures that we draw when we're in medical school, this is your appendix here on the outside. And then your colon is like the picture frame. So if you're not actually looking at the stomach when you're insufflating it, sometimes the colon is in the way, and so you'll actually pierce the colon as you're putting in this device. And so that's why the PEG is not as commonly used anymore. Interventional radiology also has that risk as well, but they're using continuous fluoro when they're looking at the stomach, so they do have another contrast medium of air in the colon, so they don't tend to do it as often, but it's certainly being done. All right, so I think we've gone over the 4 different types of tubes. We've gone to say we really like the low-profile device. It tends to be bigger, higher flow rates, parents like it better, doesn't get as clogged with medication. We're very clear if the tube falls out before 6 weeks, before the tract is mature, call general surgery, have them come down, replace the tube. If the tube falls out after 6 weeks, parents are instructed to try and reinsert the tube to keep the tract open, because a gastrostomy tube tract can close within 6 hours, okay? 6. So 6 weeks, remember, 6 hours, remember. So if a patient comes into emerge and the gastrostomy tube has fallen out and nobody's tried to put anything back into it, there's nothing sending it open, it's really an emergency. The patient shouldn't be sitting in the waiting room. The patient shouldn't be sitting in pod B waiting for you to see 2 other patients. Okay, it takes 2 minutes to pop a tube back in. You do not need to call general surgery to do that. All right? When you put a tube back in, the parents will tell you, oh, it's a 12 French or it's a 14 French, or if you don't know, just go look at the operative note and it'll tell you. All you need to do is take a Foley catheter, your trusted Foley catheter, and you'll have this is your anterior abdominal wall here, you'll have your little tract opening here, and all you do is put your Foley catheter in here, give it lots of lube it up, and push it in as far as it will go. Okay, and then inflate the balloon with the amount of air or liquid that's stated on the catheter, and then gently pull it back until you feel it tractioned against the abdominal wall, and then you can just tape it in place. Okay, so as a continuation of the GJ tube, remember, very important, what happens if that tube falls out? And remember the rules of sixes. So if the tube falls out less than 6 weeks after it's put in, call surgery. They will replace the tube as best they can, and then they will do a tube check. If the tube falls out after 6 weeks of surgery, then you have about 6 hours to get that tube back in, because otherwise the tract will close. So you can't have a patient sitting in a merge, going through triage and then taking 4 or 5 hours to get into a bed, because remember, the tube fell out at home. So there's been travel time and recognition time. So you have to be very quick about it, okay? If a patient comes in and the parents tell you they usually have a 12 French Mickey, then the first tube size that you're going to try and replace is going to be a 10. If that doesn't work, you keep going down. 8 and 6. Okay? If you can't get in any of these tubes, then what you need to do is call surgery and see if they can help you. If they can't help you, they will make the decision to probably go to interventional radiology, and for interventional radiology to place a guide wire and then to re-dilate the tract for you. Okay? So this is a very important point. Okay, now what I just want to run over next is one last thing before we move on to our next topic, is the topic of a leaking G-tube, right? So, leaking G-tube. So your G-tube has been in for a while, and it's constantly leaking. And often people will say to me, well, we just need to put in a bigger tube, right? Because probably what's happened is the tract has got a little bit big, and the tube is a little bit small. So if we put in a bigger tube, we'll fill this space. Well, actually it doesn't work like that. You put in a bigger tube, you just stretch it out more, it leaks more. So what you actually need to do is put in a smaller tube and have the parents sort of bear with it. The leakage for a couple of, usually just even a couple of hours will fix it, and then the tube will close down around it. Okay? So that's the number one problem that you'll see. The number two problem that you'll see is heaped up granulation tissue around that G-tube site. Okay? It's not active infection, it's just an overzealous reaction to having a foreign body, and so you get this heaped up granulation tissue that looks like cauliflower. How do you treat that? Well, in the community we tend to use silver nitrate. It's really not the best. You can burn the regular skin. So now we're using beclomethasone spray. And that's the 10% solution. And we just say 2 squirts of that spray twice a day onto the heaped up granulation tissue. Okay? The third thing that I want you to try and remember in terms of just sort of complications is infection. If you think about it, the GI tract is full of bacteria, gram-positives, gram-negatives, anaerobes. So the G-tube tract itself can actually become colonized. So it's very important, if you think that there's an active cellulitis around the G-tube tract, that you really hit it hard with antibiotics as soon as you can. That doesn't mean they have to come into hospital, but if they're at home, oral antibiotics. And a very nice antibiotic to use orally if the kid's a little bit older is Cipro, because it has nice gram-negative coverage. You could use amoxiclavulin. And in weird and wonderful situations, I'll actually go to a cephalosporin plus an anaerobic, something for anaerobic coverage that's separate. So for example, flagyl. Because the last thing you want that G-tube to do is to get colonized, because then the patient's coming back again and again and again with G-tube infections. All right, so I think that ends GJ tubes. So why don't you take a break for a bit, and then we'll come back and we're going to talk about central venous access in the pediatric population. Central access, another nightmare in pediatric surgery. Pediatric general surgery are often called to put in lines, to remove lines, and to assess the patient in terms of what should we do in terms of IV access. Remember that in the back of our heads, we're always thinking NICU should be putting in their own PICC lines. And we'll go over the definitions of these in a second. And we should always be thinking, for the most part, that really general surgery doesn't have much to do with putting in lines, and that interventional radiology should be the people who put in lines. The reason for that is that over the past sort of 5 years, they're the ones who have done it the most, so they're the best at it, they're the slickest at it, and there's one very technical reason why they do it, and we'll talk about that when we actually come to putting in the lines. Why do patients need lines? Well, that's sort of a real no-brainer. They need it for IV access if they're difficult to access and you think they're going to be in on IV antibiotics for a while. If they have long-term requirements for TPN, for example, or if they're an oncology patient and they're going to be needing chemotherapy for a while. If we look at the types of lines that we're going to use, there are a number of lines, and they're chosen for specific reasons. Okay, the short-term line, so let's just rub this out for a second. The short-term lines in the younger patients, so in the neonate, is going to be the PICC catheter. So the percutaneously inserted central catheter. Okay? The longer term lines are going to be those lines that really are sort of greater than 2 weeks. But that's not a hard and fast rule, right? You have to sort of put other things into the picture. You know, there are two fundamental differences between a PICC line and the other central lines that we use. And it's really very straightforward. The PICC line is just a long tube, right? The only thing that's holding it into the patient is a suture on the skin on the outside of the patient. The other lines that we put in have a cuff on them. So if this is the skin here, this is the line that's hanging out of the patient. So this is out of the patient, and this is in the patient, and this is the skin. And it's variable depending on the type of catheter, but somewhere around 2 to 3 centimeters from the entry into the skin, you're going to find a cuff. Sometimes there's 2 cuffs. And the thing about these cuffs are that once the line has been in for approximately 2 weeks, the actual surrounding tissue grows into these cuffs. And it actually seals the line in place. This has a number of good things. First of all, this actually prevents infection because the tissue sort of conglomerates around the cuff. Prevents bacteria from egress along the line. It stabilizes the line. It makes it much more difficult to pull out. So if you have a kid who's going to go home, going home with a PICC is really tough, right? Because they can pull it out so easily and it's very easy to get infected. The lines that are cuffed lines is a whole different ballgame, okay? They're much more durable with a lower infection rate. The problem is, so you should say to yourself, well then why don't we just put cuffed lines in everybody? Well, the difficulty is that they have to be removed with a general anesthetic because this stuff, the stuff that grows into the cuff, is really tenacious. You can't just pull it out, you actually have to remove it. All right, so let's have a look at some specific lines in more detail. So this slide that we have here shows the common types of catheter that we have. We have the PICC lines, the percutaneously inserted central catheter. As we talked about earlier, the catheters that have a cuff that are more permanent. So you have the Broviac catheter and the Hickman and the Groschon. Basically, the Groschon is a dialysis catheter. So we're just going to put that aside for a minute, just remember the name. The two that you're going to need to remember are the Broviac and the Hickman. You need to remember that a Broviac is basically a smaller Hickman, or a Hickman is a bigger Broviac. And then the third type that you all know about is the portacath, the implantable reservoir. So the portacath is the kind of the colloquial name for the implantable reservoir. It's really quite obvious when you choose a Broviac over an implantable reservoir. The implantable reservoir has no external components, so it's great in terms of being, the kids can go swimming, they can go in the bathtub, they can do all of those things. It's easier to care for because you don't have this line hanging out. But the key thing is that you can't have it accessed 24 hours a day, 7 days a week. So if you're on home TPN, for example, a portacath is not a good example. But if you're just coming in for weekly chemo and maybe a 4-day hospital stay, where you're going to be in hospital and you're not going to be going out of hospital, then a portacath is a very reasonable option. So let's concentrate on PICCs. Remember, this is what the PICC looks like at the skin. Okay? Remember, no cuff, very important. No cuff, only held in by a piece of sticky tape and a little, maybe a stitch here. And this is what it looks like before it's gone into somebody. A very smooth, very thin, very long catheter. As we noted, they're usually temporary. They can be a double lumen tube, but often they're not. They're often used in the NICU. They can be inserted by nursing at the bedside, usually under ultrasound guidance. And they can be placed in many, many different places. In the older kids, usually in the arm, but in the neonatal population, oh my goodness, they could be anywhere. The longevity of the catheter is basically highly variable depending on the patients. In the older patient, obviously, they can't go home with them. The Broviac catheter, which is the one that you're probably most familiar with in the smaller pediatric population, looks like this. Okay? The cuff is hidden up here. So this is an ideal catheter for longer-term access. As I mentioned, it's usually placed by interventional radiology. So that's a difference, right? The PICC can be placed by nursing, and the Broviac is usually placed in interventional. They use ultrasound guided, and then it's a peel back sheath type insertion. So basically what they do is they find the vein with a needle, they pass a guide wire through the needle into the vein, and then they pass a peel back sheath into that, over that guide wire, and they pass the catheter through the peel back sheath. Where do they put them? They most commonly put them in the jugular veins. They are the most common sites. They can put them in other places, and as children get older and lose central sites, they can put them in many, many different places. We as pediatric surgeons can place them in the operating room, but as I mentioned, the real issue is that interventional probably does more than we do. They have to be removed under a general anesthetic in the operating room. So I think we've basically gone through this slide. The Hickman catheter is similar to the Broviac. Essentially, it's just bigger. And it usually has 2, if not 3 lumens. It's very commonly used in bone marrow transplant patients where they need big volumes and high flow rates. Usually, again, inserted by interventional radiology, and usually removed by the pediatric surgeon in the operating room. In fact, I should say they're all removed by pediatric surgery in the operating room because they have a cuff. In pediatric surgery, none of us like putting in Hickmans because usually they're asking us to put in a huge line in a relatively small patient. So in terms of line insertion, we can be consulted to say, okay, would you put this line in this patient? Which line do you think is best? And what's your availability? And usually we like to defer to interventional radiology for these lines. The implantable access devices, so the portacath, shown here in a nice little picture. Remember, the portacath does actually come in many different varieties. There's the low profile flush, there's the high profile for the patient who's slightly more obese, there's the MRIable port, although most of them are now, but they come in many different shapes and sizes. And so interventional radiology, who you will go to, usually to have a port put in, will determine what type of port. As you know, they're usually placed, the access device is placed in the chest, and it's ideal for intermittent therapies. In theory, the infection rate is less, but it depends on how the port is accessed. To reiterate, put in interventional radiology has to be removed in the operator. Okay, now we're moving on to, I think, probably the one which a lot of people really don't understand. And it's not that they don't understand what the tube does, it's what they don't understand is this piece of equipment here, the pleurovac. Okay, and so probably the main thing about this talk and the take-home message about this is going to be understanding the pleurovac and how to actually look at it and not be scared of the pleurovac. All right, so first let's start off with a little bit of thoracic anatomy. So we know that in the chest cavity, when we take a breath in, we create a negative intra-abdominal pressure. Okay, that keeps the lung expanded and it allows the lung to re-expand. Okay, we know that whenever you get air or fluid inside the pleural cavity, it disrupts that negative pressure and the lung collapses. Oops. So the lung collapses. So what is the goal of a chest tube? So this is our lung, and this is our pleural space here. Okay? Remember, the lung is like a sponge. So if it's air that's escaping, it's because lung in the, or air in the parenchyma of the lung is escaping out. If it's fluid that we need to drain, it's fluid that has been produced by either an inflammatory reaction or an oncological reaction in this pleural space. So the whole thing about keeping this lung expanded, about keeping it up, is to make sure that this space stays as empty as possible. Empty of fluid or empty of air that might be escaping from the lung. We need to keep those two parietal surfaces, so remember the visceral surface and the pleural surface together. So we need to keep this edge here opposed to this edge here. Put that one there. Okay? It's very important. So can I have the next slide? So the indications for a chest tube, for a thoracostomy tube, will be to remove air or to remove fluid. Okay? The fluid can come in many forms. It can be in the form of pus as an empyema. It can be in the form of chyle or a chylothorax. It can be caused by a post-operative complication such as in cardiac surgery. Those are sort of the non-emergent reasons to have to drain fluid. In the emergency situation, what are you looking at? You're looking at draining air, or you're looking at draining blood or contamination. So a pneumothorax is going to be when you drain air. A hemothorax is going to be when you drain blood. And a contaminated thorax is likely a result of an esophageal rupture. These are really the three emergent reasons why you will put in a chest tube. You all know the signs of a tension pneumothorax, and I'm not going to go over it. And if you don't know them, well, then you'd better go learn them, okay? So we all know about air. We all know about what blood does. It does exactly the same thing as air. I don't think it does anything different. It does exactly the same thing. An esophageal rupture, which is associated with your contamination, is probably going to be more of a systemic febrile response, a systemic septic response. All right? So how do we remove air, blood, and contamination? Well, we put in a chest tube. What size chest tube do you want to use? Well, they come in many different sizes, and they come in the rule of 4s. So they go up by the sizes of 4, so a 16, a 20, and a 24. And usually, it's around 4 times the size of an ETT tube, so an endotracheal tube. Now, however, having said that, you have to be a little bit cognizant of what you're doing. The studies used to show that if you had blood or contamination, you needed a big tube. But now the studies are showing that really small chest tubes are just as good as big tubes. And so we're not quite as gung-ho as we used to be to say, okay, it's blood, we've got to put in a 24 or 28 size chest tube. We can actually probably just get away with an 18 now. So bear that in mind when you're thinking about what size tube you're putting in. So we put in our chest tube, and I'm not going to go over that technique because everywhere in the hospital somebody does it slightly differently, and they'll teach you it slightly differently. In the intensive care unit, they use the classic Selding technique. In general surgery, where we really only put them in the operating room, now we just use the old classic way of inserting a chest tube. And in interventional radiology, they do their own thing. Okay, so in reality, really, the only place you're going to be putting in a chest tube is in the intensive care unit. But I think it's really important that you understand what happens when you put in a chest tube, okay? And what happens to the end of that chest tube. So let me clean the board for a sec. And then we'll get into it. So the drainage system is what we're going to talk about. And the drainage system activates a response in the surgeon or in the person caring for that chest tube to look at three components of that drainage system. It activates the response around the suction, which is actively sucking the thing you don't want in that pleural space out, right? So whether that be air, fluid, blood, chyle, you name it, it sucks it out, okay? The other one that you'll hear us talk about is water seal, or in a more colloquial term, is straight drainage. So we put the chest tube to straight drainage, Dr. Jones. And you're like, oh, I wish I knew what that really meant. So we're going to tell you. And the other one is something called a clamp trial, which in pediatrics, in all honesty, we really do not do unless we are very unsure of whether we have actually managed to stop the egress of either air or fluid. And very occasionally we'll do a clamp trial, but we'll talk about that in a minute. So for the moment, really try not to think too much about a clamp trial. Okay, so we're going to now look at specifics around the drainage system. So let's first look at suction. Okay, so suction actively sucks air and fluid from the chest cavity. Okay. Water seal passively allows the fluid and air to escape from the chest cavity. And then we've got our clamp trial again. Something's happened. There we go. Okay. So if we look at our pleurovac here, and I'm going to go through this with you. This is the pleurovac. So we're going to point a few things out. This here is what we call our water seal chamber. This here, okay, and it starts at 10 here and goes up to 200, and then 300, and then 400, and then up here. This is our fluid collection chamber. This unit here is our suction control, and we can set our suction. Okay? This piece of tubing goes to the patient. All right? And if we're going to put our chest tube on suction, the suction goes right here. All right? So the collection chamber, so that's this column here. Okay? It collects whatever is being sucked out or passively allowed to drain from the chest tube. So it can be blood, serous fluid, or chyle. Okay? Anything, in fact. And it collects in this chamber here. So you can see it, you can mark it on a day-by-day basis, and you can look at how the quality of that is changing. The water seal chamber, and this is a complicated one. This is the one that messes with everybody's brain. So remember the word bubbles, okay? Bubbles is the big one. So this water seal chamber, it acts as a one-way valve, okay? So it allows air to come out from the chest tube, but it doesn't allow it to go back, okay? Now, in a pleurovac that's being used, you'll see that there is blue fluid in here, and it's filled to this line here. Excuse me, filled right here with blue fluid, and there's also a column of blue fluid that goes up here. Whenever the patient takes a breath in or out, the pressure in this system, in this tubing, changes, okay? It is reflected in the way this blue line moves up, this blue column of water moves up and down. So to see the column of water moving up and down is fine. However, if you see bubbles coming up through here, what you're seeing is air that's come out of the chest tube, it's gone into this tube, okay, and now it's traveled through the collection system and through into this underwater seal. So you're seeing air coming up through here, okay? If your patient is on suction, so if you have the suction level set here, you're actively sucking air out of the chest tube. And if you see bubbles here, you know that you still have air that needs to be sucked out, i.e. the patient has a leak. If you have it on suction and you don't see any bubbles here, then maybe your leak has closed. So then what do? You put it to straight drainage or to underwater seal. So, how do you describe to me what's happening in this one chamber, right? In this water seal chamber? Because I need to know, is this device sucking air out of the chest cavity, or is it doing it on a continuous basis? Or is it doing it on an intermittent basis? Or is it not sucking at all? Is it doing it with a cough? Or is it doing it with occlusion of the drainage system? And these are the four descriptors that you use when you tell me how much air is leaking out of that person's chest, all right? So, if it's a continuous leak, so you take your breath in, you blow out, and the air comes flowing out of that pleural space and it passes through this system, the bubbles here will be continuous and they'll be going bubble, 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 right? What you don't want to see is actually what I just did. If you see that's really bad and you need to call somebody. That either means that you have a leak in the system, so a leak here or a leak in a connector, or you have a huge hole in your lung, okay? If you just see the what we call intermittent bubbles, so you see boop, 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 you know, like the little fish tank, boop, 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 boop. That's what we call intermittent, right? And that is, that's a good sign, right? That's the start of things getting better. When you stop seeing the intermittent bubbles and you only see bubbles with a cough, what's happening? What's happening is that over time, what's happening is that there's not enough air in that pleural cavity to be sucked out. But when you increase your intrathoracic pressure and you go, you squeeze the air out. And so then you see a few little chain of bubbles coming up through here. So you see a little boop, 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 and then it stops. Okay? You can apply the same sort of principle to that as what we call occlusion of the system. So I didn't see any bubbles, Dr. Jones, when I occluded the system. So where do you occlude that system? You occlude the system either at the level of the chest tube, or at the level of the suction tubing, which is here. You occlude it for about 30 seconds to a minute, and so what you're doing is you're stopping the system suck any air out, and when you open it again, if you still have a leak, more air will have accumulated in the system, and you'll see it bubbling through here. Okay? So, remember those ways, and that's how you describe it to me over the phone. Okay? Remember that the height of this water column here, so the height of the water column, so you've got your little chamber here, and then you've got your water column here. The height of that water column regulates the amount of negative pressure in the tube, okay? The amount of suction that we apply to the tube is variable. It can go anywhere from 40, 30, 20, 15, and 10 centimeters of water, remember, right? Centimeters of water. So it's in effect underwater seal at this amount of suction. It doesn't matter what the suction at the wall is. The chamber regulates how much suction is actually put on this tube. All right? And we know that the system is sucking by this little orange ball here. When the orange ball rises, when we apply suction here, okay, when this orange ball rises, we know that the amount of suction that we set with this dial is okay. So you're going to go, well, Dr. Jones, what do we start off with? Usually we start off with minus 20 millimeters of centimeters of water. Okay? If we want more, we go up to minus 40. But that's very rare that we use that. We want less, minus 10. The sort of gold standard is minus 20. All right? Okay. So remember, bubbling in here indicates that air is passing from the chest into the chest tube and then into the system. Okay, we also recap that you can check to see if there's an air leak. If you don't have any bubbling here, by getting the patient to cough or by occluding the suction tube. Remember this. This column of water here always moves up and down, okay? And it moves up and down with normal respiration. So if you don't see this column of water moving up and down, it's not a gold standard, but you need to think about, is your tube still working, right? To see fluid in here fluctuating with each breath is perfectly fine. So now we're going to talk about some of the pleurovac troubles. Okay, pleurovac troubles. So one of them I've already alluded to, and that's if you see a continuous, very forceful stream of bubbles coming up through here. Okay, so if you see a and the noise that it makes is actually very similar, right? You'll actually hear it going. That tells you that you either have an extremely large leak in your system, so you have a large leak, and that leak is coming from a number of places. It can either be coming from your lung, it can be coming from your tubing system, it can be coming from where the tube goes into the chest wall. And if that's the case, it's coming from one of the holes in the chest tube. So remember, a chest tube has a length to it, right? In order to suck out the air, the end that's in the patient has a number of holes in it, like this. If the chest tube has migrated out of the chest wall, these holes are exposed to the air and they'll suck air like there's a huge leak. All right? So if you have a huge leak, that's what you have to think about. The worst thing with a large leak is that you have developed a bronchopleural fistula. It would be very uncommon, but it certainly could occur. So they're the things that you have to think about. So the main thing is going to be check your tubing system, think about the operation the patient had, and then troubleshoot it. All right, what else can go wrong with the pleurovac? Well, the patient can develop a tension pneumothorax. We all know the signs and symptoms of a tension pneumothorax, so I'm not going to go over them. If you don't know them, I'm going to go and refresh your memory. A tension pneumothorax with a chest tube in place results for a number of reasons. Number one, the chest tube can't keep up with the leak. All right, so the chest tube cannot keep up with the leak. So that would be when you have and you need two chest tubes. It's the bottom line. The second case is if the tube is inadvertently clamped or kinked. What's the most likely one? This one. In pediatrics, kink, 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 kink. Chest tube not working, lung gets collapsed, chest tube kink, 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 kinked, okay? Very, very rarely do we clamp tubes on the floor. This is really a no-no because we don't want to get a pneumothorax. Okay, so what's the third thing you'll see? The third thing you'll see is huge amounts of subcutaneous emphysema. And here you should, without me even talking anymore, be able to figure out why that is. Okay, it goes back to the tube and the holes. Holes out of the thoracic cavity, but sitting in the subcutaneous tissue means that you get a lot of subcutaneous emphysema. So you need to check the position of your chest tube. The other time that you see subcutaneous emphysema is if you have a huge leak and you're not keeping up with it. All right, so they're the things that you need to think about. Okay, enough about pleurovax because I've had enough of those things. Okay, so remember that chest tubes are put into it to remove what? Air, pus, or fluid. So any elective chest tube insertion, I think in this day and age, should probably be done in interventional radiology. Right? And why do they do that? Because they can use ultrasound guidance, and so they can get a very good positioning of the chest tube, especially if it's for loculated fluid. How do you determine if you have loculated fluid in the chest? You're going to do an ultrasound. Okay? You are not going to do a CT until you have done this. All right? So that's good. Anything in IVR, just as a reminder for anything else that you're doing in IVR, requires a general anesthetic. And actually something I haven't remembered to tell you is that they always need an INR and a PTT. Okay? They will not put in a chest tube without, or a GJ or a central line without an INR. We're not going to get PTTs in the small kids, but without an INR. All right? Okay. So, if we're inserting a chest tube into the chest because we have a large pneumothorax, where's the air going to go? Just as a reminder, the air is going to go into the tube, and then it's going to go into our water seal. Okay. In the case of an empyema, we don't expect there to be a pneumothorax. Okay? We expect there to be fluid that is going into the atrium and then going into our pleurovac system so that we can measure what it is. Okay, on your slide deck, you're going to see a number of things about empyemas that are useful to you in terms of looking at diagnostic criteria for an empyema versus just a straight loculated pleural effusion. But we know that the best way to diagnose the empyema is with ultrasound and then possibly CT. Also on your slide deck, you're going to see an algorithm for looking at an empyema. So the first thing that you're going to do in terms of the algorithm of an empyema is to look at the patient, fever, chest x-ray, ultrasound. Okay? Ultrasound, loculated effusion. And then you're going to go to two arms with your loculated effusion. You're going to go to thoracentesis, so drainage, plus or minus TPA. And on the other arm, depending on the location that you're in, you could possibly go to a video-assisted thoracoscopic decortication. And I'm telling you this just because in other centres, this is what they do. What do we do here? We tend to do this. Okay? Before I came to London, I always did this. The data shows that actually you have decreased length of stay, but increased, you can get an increased morbidity. You have a number of patients who may develop a bronchial pleural fistula with doing this up front, but you can decrease your hospital stays by over 50%.